Ma'am, please start. Thank you.
Mm. Good evening, sir. Uh, 11-year-old boy, second by birth order, born of non-consanguineous marriage, resident of Miraj and Hindu by religion, brought by parent with complaint of weakness of right upper limb since 7 days and weakness of right lower limb since 5 days. The child was apparently all right 7 days prior to the presentation. When he developed weakness involving the right upper limb, the weakness was sudden in onset, gradually progressive in severity. Initially, the child has difficulty in lifting the right hand during the activities of daily living, such as eating, which subsequently progressed to near complete inability to move the right upper limb. Approximately 2 days later, the weakness extended to involve the right lower limb also. Initially, the child experienced difficulty in walking, which was associated with frequent falls while walking. And over the next few days, the weakness progressively worsened, ultimately leading to complete inability to walk. The weakness was progressive, not associated with diurnal variation, and not associated with aggravating or relieving factors.
Yes.
On further inquiry, child has a history of headache since 2 days, which was sudden in onset, intermittent, throbbing type, not associated with photophobia or phonophobia. No history suggestive of cranial nerve involvement. No history of sensory symptoms such as numbness, tingling, loss of sensations. No history of bowel or bladder incontinence. No history of seizures. No history of fever. No history of preceding infection. No history of trauma. No history of omitting or visual disturbances. No history of loss of consciousness or altered sensorium. No history of similar complaints in the past, no history of Cox or Cox contact, no history of similar complaints in the family member. For the above complaint, child was admitted in some other hospital where IV medications given, neuroimaging done, and referred child to our side for further management. In past history, at 10 months of age, child was operated for some heart defect. After that, no history of admission. ANC history not significant. Registered supplements were taken, TT injection taken, 4 ANC scans were done, which was told to be normal, and no history of ANC related complications in the mother. Birth history, full term normal vaginal delivery. Birth weight was 2.5 kg. Baby cried immediately after the birth. No history of NICU stay and discharged on day of life 3. Developmentally history, school going children, studies in 5th standard, and good scholastic performance. Immunized till date. Dietary history, mixed diet from the family pot involving all food groups. Family history, 35-year-old father, 32-year-old mother, and he has a one elder sibling which is 14-year-old, and patient is 11-year-old male child, and he has a younger sibling 9-year-old.
So this is an 11-year-old who started with weakness of the right upper limb, right? First. So for the first 2 days, there was only weakness of the right upper limb. So at that time, what would be your thought process? Means what you have to decide is what is the anatomy of this weakness. So is it a local problem? Is it a spinal cord problem? Is it a central problem? You have to think that way. So when he comes with inability to move one hand, what would be your thought? How will you proceed?
First, rule out the local problems.
Ask pain.
Very good. So the first question is pain. So is there any pain? So many local causes would be associated with pain. So there is no pain. So now in general, suppose there is a weakness. It is with pain and without pain. What is the difference in your thinking? Which one is neurological, or both can be neurological, or neither can be neurological? Okay, explain.
Because if neuropathy is associated, which is causing weakness, it is usually associated with pain, sir. So
Little better word. Example. In which weakness you get pain and then weakness? Very good. So radiculopathy, GBS. Very good. So there is pain as well as weakness. And suppose there's no pain and only weakness, can it still be neurological?
yes, sir.
Yeah, it can still be neurological. So many painful conditions, the child may not be able to move because of the pain, but there's no actual weakness of muscles, right? Fine. So that you ruled out one. Now, just to increase your thought process, when we say local causes of not able to move a limb, what else will you think of? And in what situations you can't move a full limb? Thoughts? Come on, any thoughts? Let's give you example of lower limb. Something happens and I can't move my one lower limb.
Of the hip.
Yeah, very good. But that doesn't happen suddenly. Yeah. We are talking of sudden causes of not able to move a limb. Very good. So trauma, fractures, all that is all acute. So in short, those local causes will be very obvious with some kind of a history. Okay. Now come to separating it from neurological causes. So peripheral nervous system, spinal cord, and center. How will you separate it out in your mind? Suppose I have muscle involvement, or my main axillary nerve or some such nerve is traumatized, or something is gone wrong. How will you make it out?
Only corresponding muscle weak.
Very good. Only corresponding muscles will be weak. So full limb, all joints, all muscles is very unlikely to be a peripheral nerve problem, right? So that is gone. So now spinal cord and center. Come on, others also. Keep thinking. It's just, we are just learning. There's nothing right and wrong. Even if we speak wrong, it's fine. How will you differentiate spinal cord and center?
There is involvement of bowel bladder involvement. I think it can be different. Spinal involvement.
That is one point, bowel bladder. But first tell me, if you're talking of one limb weakness in the spinal cord, where should the problem be?
This
Means you are saying anterior horn cell. So it, for just one limb weakness, it has to be a unilateral problem in the spinal cord. That is one. Second, it has to affect multiple nerve roots which innervate that limb. The like just like you said, the nerve. There's only no one nerve which innervates the whole limb. Similarly, there's only no one nerve root which innervates the whole limb. So it has to be a unilateral problem from, let's say, C7, C8 to T3, T4. Then one limb will be affected completely, right? And what will be affected? Sensation often, right? Okay. Coming to center, where when means can you get a problem because of which only one limb is involved, some central problem. So where is the innervation of the upper limb on the cortex? Lateral surface of the cerebral hemisphere. So only that area can get ischemic? No. So what we learn out of this exercise also is that usually when there is one limb affection, if you rule out local causes, you are expecting a lower limb problem sooner or later, or it is already there. It's part of a hemiplegia which you have to fish out.
I think we are all aware of middle cerebral with a sudden paralysis of one side. But then there are branches further. So if one branch gets first blocked, then you have just some one limb involved. But then, as he said, you look at the possibility of it extending to the basic artery itself. And therefore, in pediatric practice, monoparesis of sudden onset is almost always hemiparesis to develop. And that is what has happened. So because it's sudden, you consider a vascular cause. Any other cause that can happen suddenly, then we will only go with a vascular problem ahead. So what else does happen in neurological disorders suddenly?
Embolic causes can be there. Embolic causes can be there, or hemorrhagic causes can be there.
Hemorrhage, okay, vasculitis and vasculospasm. 5 types of vessel problems. Okay, most common being thrombosis, of course, but you can have an embolism coming from somewhere. You can have a vasculitis. Separately, one vessel is unlikely, but you know the rheumatological disorders come as vasculitis, and we know that Kawasaki is one vasculitis, localized. So we'll keep that in mind. And vasculospasm is seen in some of the metabolic disorders. So we keep all that in mind, but that is all vascular. Anything other than that pathology and something that happens suddenly is mechanical, that is out here, allergic, so immune disorders. Acute immune disorders could have such manifestation, but generally it is much widespread and not localized. And to that extent, you know, acute immune encephalitis, antibody related encephalitis, all that is all. But even immune disorders also could be localized, like you can have an acute immune cerebellitis. Only cerebellum is involved. But this is only one limb involved. That looks unlikely, and therefore that is what it is. Could it be a very fastly developing tumor?
Actually, it looks like a tumor only because the lower limb happened after 2 days.
And headache also.
Yeah.
So do you think tumor is likely? It started in a motor area serving the upper limb, then it started enlarging, also affected the lower limb, and because of its expansion, it started getting headache also. So how do you consider pros and cons of it being not vascular but a space occupying lesion? Any thought? See, we don't need to know neurology. We
No.
need to know the basics of how you argue, right?
In case of vasculitic, sir, if it's in case of vasculitic, if it's vasculitic lesion, then in case of embolic, the onset of paresis will be maximal at onset only, and then there will be improvement. And in case of hemorrhagic stroke, there will be catastrophic manifestation at onset only. And in this case, there is a gradually progressive weakness, which happen in case of any intracranial space occupying lesions.
In terms of space occupying lesions, there'll also be vomiting, which is not mentioned. Other symptoms, fever will also be there.
Fever may not be there.
Huh.
Vomiting as a sign of raised ICP, yes, but there is headache.
Okay.
So now we want you to do two things. Before we argue about space raised ICP, just logically think where should a tumor be to first press on the upper limb and then press on the lower limb to cause paralysis. Think and tell us. So can you have a tumor on the lateral surface of the cerebral hemisphere, which first knocks off the upper limb area and then the lower limb? Incidentally, where is the upper limb area? No, convexity, medial side, lateral side.
Literal.
So can you have a tumor there, big tumor which affects, that's a big area, no? Upper limb is represented by in a very big area. So all that area, there's a tumor.
There is no sensory involvement in this case. Had it been a vasculitic cause, there would have been sensory involvement as well.
Okay, we'll come to that. But first think about location of a tumor. You getting what my question is?
If there is any lesion in the motor area, what's the first symptom?
That is a which, what area is that? Matlab, gray matter, white matter, motor area. Gray, cortex. So what is the cortical symptom?
You have a tuberculoma there.
Seizure.
Seizure.
Focal seizure. Okay. And then weakness, yes. So localization. So it's out. Then why is the headache there?
So look into your description of the headache. What is the description of the headache and then what does it mean to you? And what kind of headache you want in raised ICP? Come, sit here. Sit.
Sir, on further inquiry, child was complaining of headache since 1 to 2 days, which was sudden in onset, and it was thrombing in type intermittently and mild to moderate in intensity, and headache was not associated with other symptoms like photophobia and phonophobia.
Fine. So what is your interpretation? Does this look like a raised ICP headache? Yes, no. What do you think?
What do you mean by throbbing? You have used the word throbbing. What does it convey to you? Throbbing. Okay.
Where else do you use the word throbbing? So one is migraine. So throbbing is related to what? Vessels. Excellent.
Okay. Can it be abscess? Throbbing headache.
It can be.
Can you think this could be an abscess?
It can be, sir, abscess.
Tells me it cannot be.
Sir, cerebral abscess is infectious etiology. For infectious etiology, in this case, there is no history of fever and all.
No question, no. High fever, all that. And therefore, this is my Now, can migraine cause weakness? Well,
Yes, yes, of course it
so
can.
one vascular, okay. And we would like to know what's the progress of this, right? Right?
One small thing, when they complain of weakness, on history, you try to ask them, is it the entire whim which is affected or part of? The whole approach changes. If he says, I'm not able to move the hand, but if you ask them, elbow move karta hai, can you move the head? Then it is not the entire hand which is affected. So we assumed that it is the entire hand is affected, but it may not be so. Especially if there is involvement of the upper portion around the shoulder. He will say, I can't move. But can you move the fingers? Yes. Will you be able to flex the hand a little bit? Yes. So we make sure that it's the entire limb which is affected first, and then try to see even in the limb whether there's a variation in power. If the power around all the joints is affected the same way or no. Because if there is no such affection, then you come to a different localization that only some part is affected now. So on history, you should need not assume that the entire limb is affected. The part of the limb and which part is affected the most. If it is the entire thing which is affected, then you can come to a, then our thinking will go the way that we thought. Even then there can be a difference in the affection. Sometimes it may not be easy to get it out from the history.
So we've discussed that it could be migraine related, and then we discussed various things of which we said vascular is likely. Within that, you rightly said embolic maximal weakness at onset, hemorrhage is catastrophic. So those two seem less likely here. So which else vascular is possible here?
Thrombotic.
Okay, thrombotic is possible. In migraine, what happens? Vasospasm. So how will you know that this is just vasospasm? It will recover quickly. So you have to observe, and so usually migraine will be associated with a transient paralysis, which will soon recover. So this is now how old? First 7 days upper limb, then 5 days lower limb. But still both are,
Gradually progressive weakness.
so therefore now almost spasm is ruled out, right? So therefore we are on thrombosis as a possibility if it is vascular, right? Okay. Any guess on etiology? Why could this have happened?
At 10 months of age, child has a history of operated heart defect.
How can that be related, and take it forward? Means suppose there was a heart defect, we assume it was a left to right shunt. If it was a shunt, then that is already operated and it was at that age. So how could it have caused either an embolus or a thrombosis today? And what kind of shunts are usually associated with CNS problems?
Usually right to left shunts are associated. Paradoxical embolism will be there, sir.
One is right to left shunts are more associated. That is one. Secondly, how can that be related now? So some lesion may develop vegetations at that site over a period of time, but it's not common. But that can happen, and then the vegetations can get dislodged and may cause a embolus, right? Okay.
You said the problem is progressive, right? What do you mean by progressive? After all, my one limb is paratic, isn't it? Where is the progress now? Then it went to leg. it got paralyzed. Is the paralysis progressive, or only progression means upper limb to lower limb?
Paralysis also progressive, sir. Initially, the child was not able to raise his hand above the level of head, but over the period of time, he was not able to move his hand. And in case of lower limb involvement, initially there was a deviation, matlab there was a difficulty in walking associated with frequent fall. And over the period of time, there was complete inability to walk. So there is progression in paralysis part also.
So, do you think the disease is progressive, or it's the symptoms which are progressive? Okay, I'll give an example. I have a typhoid fever. Now, first is moderate fever, then high fever. The disease is not worsening. My symptoms are worsening. I fall down and get a bump here. Okay, I start getting pain. After 4 hours, I get swelling. It's not a progressive disease. It's just progressive symptoms. So, what you are trying to say is that the paresis was mild, then became complete. Okay, that's what you mean by progress. But the disease has remained in the same area. So, disease has not progressed to get involved into another. So, to that extent, all that you are trying to say is that the paresis came up worsening slowly. And which kind of vascular problem will worsen slowly? That means the vessel obstruction is getting more and more complete. To begin with, it was not so complete. Thereafter, it is complete. Which type of embolism could do that? Hemorrhage could do that. Thrombosis could do that. Spasm could do that. Vasculitis could do that.
Vasculitis, in case of vasculitis, there will be progressive.
So what you're trying to say is that two types of pathology out of these five look to be possibly increasing. One would be a thrombus. Thrombus can go on increasing. And as it increases, it obstructs the vessel completely. And the patient will say, now I have total paralysis. That is one kind of a situation where it kind of a progresses. Vasculitis is an inflammation of the vessel. That could also theoretically be increased, but in a small vessel, there is no chance of increasing inflammation because as such, inflammation is a swelling by itself. And we are talking about small vessel, not medium size or large. So to that extent, this must be a thrombosis more than anything by your saying that paresis went on becoming complete, right?
Fine, come.
11-year-old male child, second by birth order, born of non-consanguineous marriage, presented with complaint of weakness of right upper limb followed by lower limb, with past history of operated cardiac defect, with normal ANC and birth history, developmentally appropriate for age, immunized till date, without history suggestive of cranial nerve involvement, without sensory and bowel bladder involvement, is a case of right-sided hemiparesis, most probably due to the thrombotic cause uh, or intracranial space-occupying lesions. On examination, child was afebrile. Pulse rate was 92 beats per minute, regular in rhythm, good volume, no radioradial or radiofemoral delay. Respiratory rate was 20 per minute. Saturation was maintained on room air. Peripheral pulses well felt, central pulses well felt. Extremities warm. BP was 104 by 70 mmHg, which falls between 5 to 50th centile. And on anthropometrically, weight is 20 kg, height is 120 centimeter, that is less than -3 standard deviation. BMI is 13.8, that falls between -3 to -2 standard deviation, and head circumference is 51 centimeter. Anthropometrically, child is thin.
So this anthropometry, does it not fit into a chronic systemic disease?
It can, sir.
So how will you sort that out?
Height is affected more. Height is 120 centimeter that falls between -3 standard deviation, which is marker of chronic.
Correct. But height is affected how much? Means what is the height age? 120 is normal at what age? Anybody? 8 years. Very good. And weight 20 kg is normal at what age?
6 to 7.
7 years. 6 is 18. So 7 years. So weight is 7, height is 8 in a 11-year-old. So it is nearly
So height both are affected.
correct. But usually when we say that there's a systemic disease, then weight is much more affected than height. Okay. So whenever weight and height are nearly same, then you have to think whether this is constitutional. This is the family build. Now, if he was having a systemic disease which brought down his height from 11 years to 8 years, means so much affection of height, that means he has been unwell for a very long time. That would show clinically. So you will be able to make out on history that he has been sick, not playful, etc., etc. Did you get any such history before this episode?
No, sir. Child was active and playful.
Exactly. So that is the point. So active, playful child means no systemic disease. So though first impression, this tells you that height and weight both affected. So long standing systemic disease, but this is not so. You understood?
He said blood pressure 5 to 50th centile. What is that? 5 to 50th centile. Blood pressure, just show that.
Sir, what they mean is that it is normal, but within the normal, whether less than 50th centile or more than 50th centile. As in pediatrics, because we don't get too much hypertension, when it is closer to 95th, they make a point that it is closer to the 95th. So to that extent, it is the lower half of normal. That's all.
On head to toe examination, head was normal, face normal, no dysmorphic facet, chest on chest scar mark is present, abdomen normal, back and spine normal, extremities normal, external genitalia appears normal. On systemic examination, CNS, higher mind function, conscious, child is oriented to time, place, and person, memory, intelligence, and speech is normal. Then on cranial nerve examination, there is loss of nasolabial fold on the right side.
Is not there. Is coming.
Loss of nasolabial fold on the right side, deviation of mouth to the left side while smiling, and forehead wrinkling is preserved, and rest cranial nerve examination within normal limit.
So there's a question on general examination. Did you look for any signs of bacterial endocarditis? What are the signs that you look for?
Splinter hemorrhages, oscular nodes will be there, Janway lesions will be there, broad spots will be there on fundoscopy, sir. And splenomegaly will be there. Petic purpura can also be there. Fever will be there.
They'll all be mostly febrile children. So that is one big point which is against. Yeah, go on.
On motor examination, tone, tone is reduced on right side, right upper limb and right lower limb, and it's normal on left side, left upper limb and left lower limb. Power on right side, upper limb 2 by 5 and lower limb also 2 by 5. On left side, it's 5 by 5. And reflexes on right side, knee reflex is absent, ankle is 1 plus, triceps and biceps are absent. On left side, reflexes are normal 2 plus. Superficial reflexes plantar. On right side, it's extensor. On left side, it's flexor. And abdominal reflex present bilaterally symmetrical. Sensory examination normal. No meningeal sign, no cerebellar sign, and gait can't be assessed. On CVS, S1, S2 normal and pansystolic murmur present. On respiratory system, air entry was bilaterally equal and clear. On per abdo, soft and non-tender.
So to summarize, the signs are reduced tone, reduced reflexes, reduced power, right? So upper motor neuron or lower motor neuron? Lower motor neuron. So where is the problem? Lower motor neuron, so then where is the problem? All our discussion is gone out of the window.
But according to the cranial nerve involvement, it's upper motor neuron only.
Excellent. So this is a tricky situation. So all your signs are of lower motor neuron. So what will you use to call it upper motor neuron? One is the facial. So you said loss of nasolabial fold. And second, what will you use to call it upper motor neuron?
Plantar reflex, that is extensor.
Very good. Plantar extensor. Jerks are depressed. Jerks are depressed. That's why I said that there's no sign of spasticity, surprisingly.
Why are they depressed?
Child can be in spinal shock.
Yeah, spinal shock, but it's difficult to explain. But for some reason, but at least the facial is there and extensor is there. So plantar, so we know it is not a lower motor neuron. So be careful of this in the exam, okay? Examiner is going to trick you and confuse you. And ideally, abdominal reflex should be abnormal or absent. So in upper motor neuron lesion, superficial reflexes are either abnormal, example plantar, or absent. So bilaterally symmetrical is a bit odd, just check it again.
Diagnosis, right-sided hemiparesis with right UMN facial nerve palsy, with lesion being above the brainstem level, either cortical or subcortical involvement, most commonly due to the thrombotic cause, or it can be intracranial space occupying lesion.
So on examination, have we got anything additional to call it in space occupying, or based on history only you are saying? You didn't get any signs of raised ICP, no?
On history, headache is present, but on examination, no, sir. Sir, CT brain suggestive of well-defined peripherally enhancing hypodense lesion on left parietal lobe with surrounding moderate white matter hypodensity, suggestive of vasogenic edema, and imaging feature most likely suggestive of the cerebral abscess.
Cerebral abscess?
Yes.
Just one solitary abscess.
So this is provisional report.
Child is coming.
He was operated for what?
Sir, he was operated for top tetralogy of Fallot. But child has no history of cyanosis till 10 months of age also. At that time, he was presented with complaint of regurgitation of feed.
Is his PCB high? Hemoglobin is high today. Even if he was operated at that time, later on he can have evidence of polycythemia. So you'll have to explain it can be a thrombosis to start with, which got secondarily infected in the form of, especially when he has no fever whatsoever.
So Dr. Anjali is saying that acute presentation in a SOL is either due to a bleed in the SOL or a sudden increase in edema. So why would he get an abscess? Any thoughts on that? So there are dental procedures which are linked to some abscess, cerebral abscess. Of course, a lot of things are very unusual, no fever, no other complaint whatsoever. But dental procedures can lead to some problem and seeding and all that. So you have to take a history of that in the recent past if it turns out to be abscess. Yeah, Anjali, right to left shunt, if he was operated, abscess is more common, but there's a lot of dissociation in time. That was 8 months age and now he's 11-year-old. So I don't know whether after so many years, that same thing can lead to an abscess.
I think what we must ask radiologists is what else can look like an abscess? Okay, that's my first impression. And why I'm saying this that many times if you say tuberculous lymph node, and they would say there is a caseation, but the histopathologist doesn't find caseation at all, which means that caseation and abscess look similar. This is just one example. I'm not trying to take in this child because it doesn't look like an abscess by clinical story and by examination. Therefore, we are trying to see whether there could be any other way of a radiological interpretation. And I think we must ask them all that because so is she getting an antibiotic intravenously for 2 weeks?
He is on antibiotics, sir.
Yeah, so now are we treating the patient or treating the report? So how are the counts like?
Sir, counts are within normal limits, sir.
Normal. So normal counts, normal state of health, no fever, looks little unusual. Okay, now we'll find out whether such a thing happens. But typically, a brain abscess that comes up with a cyanotic heart may come up at any time, I suppose, but more often in a shorter period. And it should come with an acute onset of high fever, headache, etc. Here, the paresis has come up first, headache has come up a little later. So possibly it is not related to the space occupation. An abscess would cause possibly a throbbing pain, but again, it's a superficial abscess that causes throbbing pain. A liver abscess doesn't cause throbbing pain, and therefore, I think that throbbing pain puts us to a vessel. The slowly worsening vascular problem looks to be a thrombosis coming up. So clinically, it is a thrombosis. Okay, and that's why we would ask the radiologist to review this. And I think what is important in all this is, have you gone to a radiologist to say clinically it's no chance of abscess? Because most of the times the radiologists are not given impression of a clinician at all. Radiologists are told, do a CT scan. So they would look at it. I think this is important for us to learn. Otherwise, tomorrow I'll start teaching that abscess can come without fever, without toxicity. And I must know how correct or incorrect such statements are, isn't it? And I'm sure we have had in this very class uh, a typhoid without fever, blood culture showing salmonella typhi. Okay, now you start wondering whether that report is right or we have missed a high fever, etc. I think it's worth noting that. Okay, you are right that you have the question is you waited till the CT report came. Okay, you waited for 7 days. So abscess was not killing him. Okay, I would have started wondering, can we wait for some more time and without an antibiotic? 7 days, the abscess has been there. History started 7 days ago. Abscess was there 7 days ago. What is it doing? It's slowly increasing. Paresis is increasing. Why should abscess slowly increase and no fever, no toxicity, no damage? Looks very unusual. Okay, I'm not trying to kind of dissociate the CT finding with clinical thing. I'm not saying CT is wrong, but it's a good idea to go and talk to them and say that clinically it doesn't look like at all. Do you have any other probabilities looking like an abscess? I think that's what is possibly important.
Any other investigations have been done in this child? Like 2D echo has been done now or something? No.
सर 2D को अभी नहीं.
नहीं. And just CBC is normal.
हाँ सर, MRI किया है, MRI आज ही हुआ है उसका, रिपोर्ट अवेटेड है.
It can be tuberculoma or a SOL, like a proper tumor. Usually it should have come with a seizure as the first manifestation. Like it's a focal problem, no? So it should come as a seizure. That's what we feel. And if it was otherwise it's an SOL, then it should come with slowly progressive signs of raised ICP before it comes with a weakness.
This is provisional report. Final report is awaited.
So we don't have the details right now. We'll move on to the second case in 2-3 minutes.
Hello. Just thinking that when we used to see ring enhancing lesion, tuberculoma or neurocystic circus, I vaguely remember that it could be also an incidental finding without tuberculoma or neurocystic circus. Okay, I will have to check my statement.
So,
But
sir,
I
you're
think
right. In fact, they used to call it incidentaloma.
yes.
Incidentaloma.
I wonder whether we are looking at something incidental and not related. I think ask all these questions. I certainly remembered that ring enhancing lesion commonly we used to call
They
it.
used to call it disappearing lesion and they used to actually call it incidentaloma.
And it would disappear after some time.
Localization of the lesion and localization of the paresis, they match each other. The evolution of the illness, all this perhaps match. So small SOL, the only question is what kind of SOL. Abscess looks little difficult. If and I
Even
think,
for a tumor, time frame is too small.
and completely overlooking the cardiac problem also looks,
And no seizure at all, isn't it? My first seizure should have been there.
because if Fallows is operated, does not mean that he gets cured for life. The problems keep on coming in the form of different things. So if somebody has associated cardiac problem, separating the two will be difficult.
Anjali, we couldn't read the whole thing, so you speak it out.
I thought that the setting is right for an intracranial abscess with fallows. We don't know the status of the fallows now. Also, if some intervention was done, then there is a nidus for an infection. That's all, or even a thrombus which has embolized.
Okay.
Good evening, sir. Uh, I'm here to present my case. Uh, so we have a 2 year, 7 months old male child, second by birth order, born of non-consanguineous marriage, resident of Morewadi, hails from Dotrewadi, Hindu by religion, brought by mother. He came with complaints of fever since 5 to 6 days, increased work of breathing since 3 days, vomiting since 5 to 6 days, and abdominal distension since 5 to 6 days. So child was apparently all right 7 days ago when he began experiencing fever associated with chills, relieved with medications, not associated with any rash. He also had 2 episodes of vomiting 5 days ago, small quantity, mucoid in nature, non-projectile and not associated with any blood or bile in vomitus. Vomiting was associated with abdominal distension, which was insidious in onset, generalized, gradually progressive in nature, associated with a 5 day history of inability to pass stools despite passage of flatus, lethargy, and poor oral intake. The swelling gradually progressed to edema of both the ankles in the next 2 days. Patient also developed increased work of breathing in the form of increased respiratory rate and chest retractions at the same time. So there is no history of cough, cold. There is no history of any abdominal pain. There is no history of any loose stools, yellowish discoloration of skin. No history of any facial swelling. No history of any breathlessness on exertion or easy fatigability. No history of any bleeding manifestations. No history of any blood transfusions in the past or gallstone surgery in the past. No history of seizures, altered sensorium, or any behavioral abnormalities, and no history of COX or COX contact. There's no significant past history of any illness or admission. The ANC history is also not very significant. The prenatal USG scans were done. There were no abnormalities. Mother had taken booster dose of TT. IFA tablets were taken, and there's no history of any comorbidities during pregnancy. Birth history, patient was a full-term normal vaginal delivery. Birth weight is unknown. Baby cried at birth. No history of any NICU stay or neonatal jaundice. The patient is immunized till date. The developmental history is appropriate for age. There's no significant family history of any blood transfusion or gallstone surgery or any significant anemia in the family. Dietary history, patient consumes a mixed diet consisting of milk, dal rice, roti, and vegetables along with packaged outside food. So the total calorie intake of the patient is around 600, and his deficit is around 500 to 600 calories. Protein intake is around 9 grams per day. Protein deficit is around 5 to 6 grams per day. Summary.
Go back. Yeah, this is come.
Yes.
So what happened to the fever over these 7 days? Is the fever continuing or it has gone?
No, sir. The patient still has fever spike. He came with around 3 to 4 fever spikes. When he came that day, he had 3 to 4 fever spikes. It was still persistent.
Pattern of the fever, low grade for 1 or 2 or moderate, now rising. Same all 7 days. Fall is unlikely, but so
Yes.
pattern we want. So slowly evolving infection. Was it not too high first 2 days, and right from day 3 it is going high? Was that so?
Sir,
Right from first day till 7th day, everything's high first, more or less the same, is perhaps less likely. Nothing is impossible, but I think it's a slowly evolving illness, infectious is origin, and first 2 days were moderate, now it's high, maybe.
What I'm trying to find
yes.
out. So he's saying it's continuing. So yeah, exactly. So one minute. So patient came with this 7 day history. So fever for all 7 days, right? Do you know? If you don't know, say no. No. Was the fever high all those 7 days?
Sir, actually, patient comes from a very rural area. The parents were reliability was not very good. They just know he had fever since the 7 days. They don't know exact pattern or
Okay,
grade,
fine.
or they don't have a.
And then the patient is here with you for a few days more.
Yes, sir.
How many?
So now it's been around 15 days since he's admitted.
So fever is still on.
No, now no. He has a long course, sir.
Okay.
He's in the PICU actually.
Okay. Fine. So initially 7 days of fever. Fine. Then 2 episodes of vomiting. So now that in those 7 days, only those 2 episodes of vomiting.
Yes, sir. 2 episodes of vomiting.
Okay. No, 5 days ago. So on one day he had 2 episodes of vomiting. I don't think that has any localizing value. So the vomiting doesn't. Now coming to the abdominal distension, you said gradually progressive with 5 day history of inability to pass stool despite passing platus, lethargy and poor oral intake. And then you have said swelling gradually progressed to lower limbs. So is it, you said edema of both the ankles. So the ankles were painful, not painful?
Non-painful, sir.
Non-painful.
Yes, just swollen.
Yeah. So now we have to discuss what this abdominal distension is. Fever, we don't have details, so we can't really discuss much. So this abdominal distension, what is it? What do you think it is? Is it fluid? Is it organomegaly? Is it gas? Is it not passing stool? So is it intestinal obstruction? What is it?
Edema is also there. So might Might be gaseous distension also, sir, as he has not passed stool also. Or it might be second cause, might be fluid in the abdomen.
Pros and cons. So, means first let me ask you, do you think this is organomegaly? Liver spleen enlargement? Yeah, generalized, but it can be, liver spleen with fluid. What do you think? So, if history is correct that this child was okay before this illness, it is too fast for organomegaly. You can't have organomegaly and abdominal distension, everything in just 7 days. It's too fast, right? So either he has to have a pre-existing disease, which means he was not totally all right prior, or then that is lower on the list, organomegaly. So you have to debate between fluid, flatus, feces. So debate. So if it was fluid, he's got edema also, lower limb. Then what would you like to say something more? I think he should be a sick child if it is fluid. So we need to ask about the general condition of the child.
Yes, sir. The child was sick looking when he arrived to the.
When he arrived, he was very
Yes, sir.
sick looking.
Yes, he was sick looking. He was in respiratory distress. So he was immediately put on non-invasive ventilation when he arrived.
So respiratory distress started when?
At the same time, around 5 days ago.
Means abdominal distension and respiratory distress started together.
Yes, yes, sir.
Okay. So that sick looking takes you away from gas and flatus. So it has to be fluid probably. And respiratory. Now question is, what is primary? Is the respiratory problem primary or is the abdominal problem? Abdominal problem can give you, suppose you have a very big ascites. You can have a little difficulty in breathing, but it won't be to the point of respiratory distress, right? So maybe I don't know whether it's septicemia and
A small child, high fever, develops distension now, maybe is going in for paralytic ileus. I think he has, as a result of sepsis and septicemia, distension after, perhaps not the fluid, 7 days of fluid, and the edema may be nutritional. He must be undernourished also, and an undernourished 2-year-old child is likely to become septic and with toxic distension of abdomen much earlier. When we have edema and distension, we always try to say that both are fluids. But here the fluid coming up so much to the extent of distension of abdomen, for which we have no explanation. I think it has started with a bad sepsis. Later on, we came to know it was an undernourished child with very poor caloric intake, but that time we didn't know that. So I think he has started with a bad illness, something like enteric fever, and he has developed distension, and now, and when he came, he was already sick, maybe something like septicemia. So he was in metabolic acidosis, maybe grunting. Quite a sick child may have been in shock, and perhaps the edema was nutritional, must have had pallor, etc., etc. So I would like to explain everything on the basis of sepsis.
I think every time we have been saying, please tell us how well the child was. The word apparently, I think, is absolutely to be now not taken up. Okay. I'm not sure whether he was a healthy child or really not healthy child. Do you know that?
No, no, sir.
No.
We didn't get a clear
So the
history.
point I'm making is that the same story in a healthy child and against unhealthy child would take us to a totally different types of disorders. And therefore, first thing we must make sure whether this child was really healthy and normal 7 days ago. If not, then the story is a chronic one. Okay, it could have some acute manifestations coming up, and therefore then edema. Now, see, if the story is fever still continues, right? So now you could have said fever for such a long time. We are not sure what this history means. Then you have said vomiting only twice, but 5 days he did not pass stool. What was the stool pattern before? What is the stool pattern now? It all makes a difference. If he did not pass stool for 5 days and he was acutely sick, then possibly he had either sepsis, paralytic ileus. But if he was malnourished to begin with, it could have been poor diet, intestinal hypotonia, there could be hypokalemia to some extent. All that could have caused this. So I suppose this history does not make us correctly analyze where we are. And the correct way you would have started saying is, was he completely all right? How would you have asked the mother whether he was completely all right or not? She would have said, yes, he was all right. So how do you know that the child was completely all right? For the parents, what is all right? He plays, he eats, all right. So for us, completely all right is different. So what question do you ask to know that he was completely all right? So his behavior, his activity, his playfulness, his happiness, his eating, bowels, urine, sleep pattern, everything normal makes a child really healthy and normal.
And development.
Developmental way, but healthy child could be either developmentally retarded or not. But when I talk about health, it's activity, playfulness, happiness, eating well, sleeping well, normal bowels, normal urine. In other words, personal history is totally normal. If that is so, then the whole situation looks acute. Fever for a long time. Now you say even
When I say development, what I meant was motor development. If it was undernourished, then motor development should have been abnormal. Maybe earlier part of life he was not so bad, like an evolving malnutrition, something like kwashiorkor. Because later on he mentioned that the caloric intake was only 600 ml.
yeah. Correct. Now, if he's severely malnourished, he has motor milestones. But I'm not much worried about developmental abnormality in this child. Okay. Anyway, I think let's look at the thing because when you have a abdominal distension, 5 days not passing stool is an important point to discuss. And I feel it could have been poor diet, hypotonia, hypokalemia, whatever. We have no idea. Okay. What we are trying to say is that we are discussing without clear history of what is there. Okay. And even now you say the fever is on. So totally how long is the fever now? 2 weeks? 3 weeks?
No, actually, sir, the patient came around 15 days ago. So, sir, for the first 7 days, the patient had fever spikes and then he was put on high grade antibiotics. So, in the last few days now, he's not spiking fevers
So
actually.
if it's 2 weeks of fever, then again we need to look at it is not all acute infection like typhoid may be 2 weeks, but not otherwise. Like, anyway, let's look at the
So,
Yeah,
summary.
you skip this, go to the next.
General examination. The general condition of the patient was sick looking. The patient was febrile. Heart rate was 150 per minute, regular. Respiratory rate was 60 per minute. Saturation was 98%. BP was 90 by 54, around 5th to 50th centile, but around near 5th centile. Peripheral pulses and were extremities was cold till ankle and wrist. Peripheral pulses were moderately felt, and CRT was greater than 3 seconds. So the patient had mild pallor. He had small subcentimetric lymph nodes palpable bilaterally. He had no icterus, cyanosis, clubbing, or petechiae. he had edema over ankles of the non-pitting type, and his anthropometrically he was falling under severe acute malnutrition with a weight of 9.8 kilos, height of 81 centimeters, and MUAC of 12 centimeters. All three falling below the third standard deviation. Head to toe examination. He was thin built. There was no facial, eye, or ear abnormalities. No facial edema. Abdomen was distended. Wrist widening was present. Genitalia was normal, and pedal edema was present. So we move on to the systemic examination. On inspection, there was a swelling over the anterior chest wall, query pectus carinatum. Over the sternal area, there was a swelling. There was no visible pulsation or venous engorgement. Palpation apex beat was faintly palpable. There was no palpable thrill. On percussion, there was dullness present in the left, third, fourth, and fifth intercostal space next to the sternum. Both the hard sounds were present on auscultation. There was no murmurs. CNS examination was normal. Tone power and reflexes were normal. Uh, Abdominal examination. Uh, on inspection, the shape was normal, distended. Umbilicus was central. All regions were moving equally with respiration. There was no dilated scars, sinuses, veins, no striae. Uh, Palpation, inspectory findings were confirmed on palpation. There was no guarding, rigidity, or tenderness. Liver was palpable, soft, non-tender, 3.5 centimeter in size, below right subcostal margin. Liver span was around 8.5 centimeters. Kidneys were not ballotable. On percussion, tympanic note was heard over the abdomen. There was dull note over the flanks. Puddle sign was positive. And on auscultation, bowel sounds were feeble and sluggish. Respiratory system. So inspection again, there was a pigeon-shaped chest. There was swelling of the anterior chest wall over the sternum. Chest movements were equal on both sides. The respiratory distress was positive. Patient was using accessory muscles of respiration. Intercostal and subcostal retractions were positive. Uh, on palpation, the trachea was central. Chest expansion was bilaterally symmetrical. Tactile vocal fremitus was decreased in the infraaxillary and inframammary region. Percussion, there was dull note positive in the infraaxillary uh, and inframammary regions. Auscultation, air entry was reduced over bilateral lung bases. So the impression in 2 year, 7-month-old boy, case of fever, abdominal pain, vomiting and increased work of breathing in a case of severe acute malnutrition, immunized till date, developmentally normal with no significant past history is most likely a case of partial intestinal obstruction with pleural pericardial effusion and ascites, that is serositis, secondary to acute febrile illness due to infectious cause. Two years, 7 months old.
What was the birth weight? Birth weight
So
of
actually, birth weight was not maybe
not
the
known.
mother does not remember.
Okay.
History?
Yes.
What is the diet again? No.
Yes, sir.
He was breastfed for some time, then after 6 months, weaning was started, and he's hardly eating, only breastfed, where he's not getting anything but just sucking saliva and not eating. Is there a history like that?
No, sir. The patient was breastfed till 6 months. After that, they started him on food. And sir, his diet is he eats 2 biscuits and 1 cup of chai for breakfast. He eats 1/4 cup of vegetables, 2 rotis, and 1/4 cup of dal rice in lunch, and around half a cup of dal rice in dinner. That's it. That is the only, and most of it he eats outside packaged food.
Not too bad, but
Come. Obviously, there are a lot of gaps in the history as well as on examination, so we are not able to make out. There are a lot of inconsistencies. I'm not trying to point out mistakes, but we need to learn. We need to refine all this, right? So the point which Khare sir was making, we all noticed that he's a 2 year, 7 month old, so 2.5. So what would be the absolute perfect weight at 2.5? Ekdam perfect, normal, perfect birth, everything perfect. 12 to 13 kg. He's 10 kg. So it's not greatly abnormal, right? But his length is just 81. Length is like a 1.5 year old, right? So that is the first thing that rings a bell. Ki, "Arey, what is this?" Now, there are many things. He is edematous. So there could be so much fluid. Now, depending on the degree of fluid, we don't know out of that 10 kg whether 1 kg or 1.5 kg is just fluid. In that case, his weight is 8, 8.5. Then it is bad. So that is one angle, right? Then coming to all your examination findings. So, uh, in the CVS, like you said, there was that dullness which you described. You have to describe right side or left side, anteriorly in the axilla or posteriorly. Same when you talk of the respiratory system, you have to describe that. Then you said subcostal and intercostal retractions. So whether once the side which you got dull should logically be moving less. So whether we got less movement on that side. Okay. So these, yeah. So there are a lot of things in the signs also which we are not able to make out. Then what about foreign sounds? Any crepitations, any wheezing? There's nothing. Okay. Then on what basis are we clinically saying pericardial effusion? Means what signs of pericardial effusion? So what are the clinical signs of pericardial effusion?
There will be a discordance between the apical impulse and if we start percussing the heart border. So
Very good. So that is the clinical sign that is described. Now, frankly, we've not seen so many pericardial effusions to have actually seen that sign, but it is logical that the statement is that the left heart border does not coincide with the apex in a pericardial effusion. What else? That is one sign. What else? Very good. Muffled heart sounds. So the heart sounds seem distant and muffled, right? What else? You could have signs of circulatory insufficiency or shock, as in poor peripheral pulses. You may have prominent veins, all that. All that you'll have to see, right? Okay. So in short, what I'm saying is all the signs that you described is difficult to add up, but broadly, this seems to be the primary problem. There is a pneumonia probably, which has led to some kind of a septic episode.
I think too extensive infection, multiple serocytosis, the cirrhosis. So we need to really look at history-wise again, as you said. That when you see a multiple serous collection, something, I think it's a child who is going to be very sick if it's due to infection. And to that extent, you say he was very sick. Is the child now? No, earlier one. Okay. And therefore, I think the story looks of an acute illness, yes, but we did not get the proper history of fever. What you could have said is he started fever 2 weeks ago. Fever was this pattern. Fever continued till 2 weeks. So origin, duration, progress of each symptom. Now we missed that. Then constipation. Again,
Sir, we can't hear anything.
Rajesh, we cannot hear.
Yes, ma'am. I said the same.
Please hold on. The presenter's laptop has discharged, so they're trying to connect with the PowerPoint, and they'll be back in 2 minutes.
Hello.
Yes, we can hear you. We can hear you. Please go ahead.
Hello. Yes.
Yes, we can hear you. Please go ahead.
Hello. So the investigations. So the CBC showed an HB of 11 with a total count of 8.11 with 78.5% granulocyte predominance with the platelets of 1,47,000. The electrolytes were 129 sodium and 3.33 potassium. The renal function test 10 blood urea and zero point 0.2 the creatinine. Total protein and albumin was 5.4 and 3.1. The CRP was raised at 119. LDH was 1195. Actually, mm, this thing actually, we got the X-ray also done. So the X-ray showed bilateral blunting of the CP angle and bilateral haziness was there. There was cardiomegaly present on the X-ray. Then we all so we suspected pleural effusion, so we got a USG done, which showed bilateral moderate pleural effusion with septations and pleural thickening, which is suggestive of bilateral empyema. The USG abdomen showed mild ascites, mild hepatomegaly, and pseudo thickening of the gallbladder wall. So after that, we got a pleural fluid analysis done, which showed exudative effusion by Light's criteria with a pleural fluid LDH of greater than 10,000, total protein of 4, amylase of 1, ADA of 60, and glucose of 11. The pleural fluid routine microscopy showed 2138 cells, 85% polymorphs, protein of 1.13, and zero sugars. Dengue, triple H, malaria also tests were negative. We also sent a TB workup, which had a negative MAN2. ESR was 43. Gene expert was negative. Pleural fluid, MJIT, and gene expert are awaited. Blood culture and pleural fluid culture were both negative. So actually, we got a 2D echo also done for the patient. The video is. We have a video of the point of care ultrasound we had done in the PICU for the patient. Uh, so we can see a pericardial effusion around the heart with fibrinous standing over this region in inside the pericardial space. Yeah. So yeah. So the 2D echo had a moderate global pericardial effusion with fibrinous strands, and there was a collapse of the free wall of the right atrium in diastole with a dilated IVC. So they were significant impact of the pericardial effusion on the heart. Next, actually, we also got a CT scan of the patient done. There was mild to moderate pericardial effusion with maximum thickness of 1.7 centimeters. There was bilateral mild to moderate pleural effusion, more on the left side with collapse consolidation of the underlying lung parenchyma. Area of consolidation with air bronchogram within and surrounding ground glass opacities were noted. in apical and posterior segment of right upper lobe, superior and posterior basal segment of right lower lobe. So this is a 2-year, 7-month-old boy, case of fever, abdominal pain, vomiting, and increased work of breathing in a case of severe acute malnutrition, immunized till date, developmentally normal with no significant past history, is most likely a case of sepsis with partial intestinal obstruction with pleural pericardial effusion and ascites, which is serositis secondary to acute febrile illness due to infectious cause, most likely being bacterial or tuberculosis.
You not got anything positive for tuberculosis, no?
No, sir. But actually, the fibrinous stranding which we saw in the pleural effusion is strongly suggestive of a tubercular cause
In the
in the
pericardium.
pericardium. Yes.
What have you treated with antibiotics?
Yes, sir. So he is currently on, sir, meropenem, vancomycin, and clindamycin. He's admitted in the ICU. He was intubated for a few days, and he's just recently been extubated.
And he is now better.
Yes, sir. Now he's symptomatically better.
You've not started AKT.
His empirical AKT also has been started, sir, around 10
So
days.
he's on antibiotics and AKT.
Yes.
Culture of the pleural fluid is negative.
Yes, sir. Blood culture and pleural fluid culture is negative. The gene expert of the pleural fluid is awaited.
How come it takes less time? No, you already got a culture, but you didn't get gene expert.
Yes, sir. Actually, initially the pleural fluid which we got from the tab was less. It was more of an empyema. So we were getting very thick, low, small quantity pus. So initial tests were sent. After that, we put in an intercostal drain. So during that time, the second time, we removed more fluid and sent it further.
And you've done GL for AFB?
Yes, that is negative.
एम्पायमा आहे आणि बायलॅटरल एम्पायमा पेरिकार्डियल एफ्युजन
Virulent pericardial effusion.
फिब्रिनस आहे so it's long standing according to them.
In short duration, okay, multiple serositis, a patient in shock. So very likely a severe bacterial infection and not TB. Okay, I won't consider it as TB. A typical polyserositis in TB is also rare. But if at all there is a serious collection without a lung lesion, then it is very acute and very healthy child, not only just average health. So to me, there is no need of an anti-TB treatment. This is a very serious bacterial infection. Now the question is it a very virulent bacterial infection? Likely. Or is it the immune system is at fault? Both the things are likely to happen. Okay, though one has seen a severe infection like this causing multiple serositis, but it's certainly not common. Tubercle looks are very unlikely. And uh, possibly, if you give both the treatment, then you will have to finish both the treatments. And one is so long. So it could have been considered whether you treat it is acute. Again, sepsis is seen. Okay, you have a cold extremity, you have a, that's not TB doing it. And therefore, I feel it's a severe bacterial infection, maybe very virulent strain. I won't jump to say immune compromised because he has had vaccinations and all that, and he must not have gone.
Have been relatively all right.
And therefore, it's a virulent bacterial infection.
Underlying undernourished or significantly undernourished child. I'm surprised that she's fighting it also with pericardial effusion, pleural. He would have had a little difficult problem earlier only.
Actually, he was very sick. Around 1 week ago, he was very sick. He was initially on non-invasive. So he was intubated. After that, he's been recently extubated, sir. Actually, we are thinking of tapping the pericardial effusion also, but on serial echo, it has been reducing by itself. So we have not tapping the pericardial effusion yet. So far, we have not got anything.
Okay, fine. So we'll stop this case here and we have the earlier child, the CNS child who has come. So we'll just quickly examine that child. Speak what all you can.
Now the uh, weakness has seemed to improve, sir. Now there is no.
No. We are learning how. So when you see a child, you start with observation. So you start with growth and nutrition, sick or not sick, and then whatever you can observe.
Child is not sick, and the nutrition, uh, the build is okay for a 7-year-old. But
11.
he's
He
being
was
11.
11.
He's having less build. The height and the weight is less for the.
I think your height of 120 is also wrong. His height looks more. You have to check the height again. I don't think it's 120. It's more than 120. Anyway, go on.
काहीच नाही. जेवतो व्यवस्थित, झोपतो व्यवस्थित, बोलतो बेलतो. म्हणजे फक्त हातपाय हलत नाहीत. हां, पण बाकी अगदी चांगलं आहे.
Go on. Observe. Further observation.
The facial deviation which we had actually seen now resolved. There is no facial deviation.
Tell him, na? Tell him to do E and show his teeth and confirm it. Many cranial nerves you can examine without touching.
Oral hygiene for an abscess to be developed. This child doesn't have a bad oral hygiene. So we are just constructing the whole thing, right?
So facial seems to have resolved. What happened when he did E? You could see anything?
There is some
Okay.
weakness on the
Okay. Fine. Then
Hello, sir. So he seems to be improving now. Okay. Again, the improvement is unlikely due to therapy. It's likely to be by itself. And I think that puts us all to asking radiologists whether there is an alternative diagnosis radiologically, because it doesn't fit in abscess at all.
go ahead. In the legs, you can see anything. Observation in the hands, you can see anything. Want to tell him to raise this hand? What is he doing? Very good. He's trying to use his trunk and his body. So he's not really able to achieve any movement there. Okay. Fine. Just anybody has a hammer? Take reflexes. Take the knee first. Tell him, always talk to the patient whenever you're doing anything.
थोड़ा सा इधर तुम्हारा पैर देखेंगे बस, ठीक है? कुछ दर्द नहीं होगा तुमको।
What was it? He was moving on his own or you got a reflex?
was not
Moving so much, no? Good. No, I'm just cross-checking you. And would you call this 1 plus, 2 plus, 3 plus?
it was not a brisk reflex.
Was not depressed either. So when she gave a history, she said depressed. So I'm saying that the UMN part is coming up now.
You could say that, but sir, I once got it. Yes. Okay, because the technique sometimes is holding up. You could say, I got it once, and therefore I know it's there. But I can't show you now. Acceptable. Because, see, when Dr. Kare did it to begin with, it looked like not coming, but then it suddenly came. So at the most, examiner will ask you, can it be intermittent? I said, no, it's not intermittent, but it's a difficulty in either patient not relaxing or me not doing it. But once I saw it, no, it has to be there.
Anything else to see? Any signs? No. No, I'm not saying you are wrong. I am saying now it is coming up, the reflexes. Which means now the UMN part is coming up.
All. I mean, some heart disease evolving. Oh, exactly. They used to walk 4 kilometers with the dapta, that is the bag, and walk and run. Davaita Sudha.
Reflex. Hmm.
Present.
You're doing very slowly. It shouldn't be so slow. It should be like a stroke. This he is breathing. So this side is possibly absent and this side is present. That's what I was telling you. No? On the hemiplegic side, it should be absent. Understood the difference? It should be quick stroke and not slowly like. Okay, chal. Thank you.
Going to might recover.
So you're not coming. No?
May predict gate, how far he will improve later on from the. It was so sad. Child who used to walk 4 kilometers. Get the hemiplegia, the thrombus. And he had a cardiac problem. He's operated and cured, and it has nothing to do with today's problem.
Okay, online friends, we stop here today. We just examined the second child and now we'll stop. Any other comments, questions, anything from the online audience?
Thank you, Rajesh. Thank you, Rajesh. Thank you, sir.
Thank you, Amdekar sir. Thank you, Rajesh. Thank you, all the presenters. Such a learning experience. Thank you very much.
Thank you. Thank you, everyone. We'll meet next Thursday.